So my name is Kris Moreels. Some words on myself. I've been working in costing and profitability for a long time, actually basically all my career. Today I'm returning the favor that Will has given us a couple of years ago to present something also at his conferences. And I'm really happy that I can do this around my favorite subject, which is healthcare. Healthcare is a little bit of a complex environment, actually. And it has some challenges. The challenge is actually that we have to do two things in healthcare. We have to improve the outcomes of the healthcare. That means if you get kind of treatment, what is the result afterwards? Are you cured, yes or no? But at the same time, we have to lower a couple of the costs. Now, there's two things about that in relation to performance management, is that we don't know any of these two things. We don't know how good the quality of our healthcare is, first, and second, we definitely don't know what the costs are. So it's a challenge from both sides, actually. And basically, the true problem is that we have to find the kind of way of restructuring the healthcare industry in a way that we can unite the interests of all the actors, and all the actors, these are the doctors, the hospitals, the insurance, but also us as patients, is how can we unite all these interests so that they work in the same way, so that we can come up with a healthcare environment in which we improve constantly the outcomes and reduce the costs simultaneously. So that's basically one of the ideas that have been developed by Michael Porter. Michael Porter is a Harvard Business School professor, he's the strategy professor, but he's also somebody who's actually working a lot in the healthcare industry. And we need to come to an environment in which we can have more innovation, because if we have more innovation, if the techniques become better, then our quality of care also increases. But unfortunately, if we think about innovation, we think immediately about increasing costs. Okay? Second, we need to have also better patient choice. At this point in time, if you get ill, if you, for instance, suggest you should have a cardiac surgery for a bypass operation, for instance, how are you going to know to which doctor you need to go to make sure you get the best possible care? There's no information available on that. It's not being measured, and it's definitely not made public to the public. Okay. So we need also an increased quality of healthcare delivery, because one of the main mistakes we make is that we think that all healthcare provided is of good quality. It is not. We all know that. Each of us have already had one of these issues where we go to a doctor, you get something prescribed, and actually you don't get cured, it's something totally different, or you get misdiagnosed. So we need to have also a system that can make sure that we don't make these kinds of mistakes. And finally, we have to reduce the total cost. Yeah. Today, the costs are increasing, healthcare costs are constantly increasing, but we don't even see an increase in quality. So we have an issue on that part. Now, Michael Porter has developed a framework which is called value measurement in healthcare. And value measurement in healthcare is actually the fact where you want to make the overall goal of the healthcare industry as a whole as being taking the value for the customer. And the value for the individual patient is the most important thing in healthcare. We need to make our patients more healthy. And in order to do that, we need to make sure that we put the value for the customer, what he perceives as a value and what he receives objectively as a value, actually as the basis of our healthcare industry. Now, also the value is very important. Not accessibility. I mean, it's important to have access to healthcare, but access is not the goal of healthcare. It's also not having the lowest cost or having a customer service or convenience that it's easy to go to the doctor around the corner. That's not what we need to have. What we need to have is a value system in which we define as the patient health outcomes. And patient health outcomes are inherently the results that we have from the cure or the cure that we get from the treatment that we got from our doctors. And we have the value is the patient health outcomes per cost of delivering the outcome. So we have to maximize the value, which means that maximizing the outcomes and minimizing the cost of the whole thing. And one other idea is also that outcomes are the health results that matters to the patient, but definitely over the full cycle of care. If we think in healthcare or healthcare costs, we are thinking about individual treatment. We are thinking about what is the cost of taking an image. Now, what has an image to do with the value for me? Okay, we have to look at it. Was that image exactly, was it necessary to give me the correct treatment, yes or no? So we need to get to that on a different way. And the same is true for costs, because costs are the total cost of care to achieve the outcomes for a patient's medical condition over the full cycle of care. Today, we look at the cost of an individual treatment. But the individual treatment can, if that was perhaps not the correct treatment to be done, can cause a lot of cost later on in the cycle. Today, our systems, the way we get doctors paid, the way the insurance reimburse the hospitals is actually based on the fee-for-service basis. So they don't even look at first the quality, and then they definitely do not look over the fact what will be the cost over the long time. So there we have definitely an issue. Now, you might think quality improvement is by definition increasing costs. Well, it's not. If quality improvement actually, and this is something that has been shown in multiple studies, if you improve the quality of your care, then actually the total cost over the full cycle of care can be reduced significantly. That means if we have more into advanced systems of costing, and these are all the reasons, or not all the reasons, but a lot more reasons, that they always tell me why costing in healthcare is absolutely impossible, right? The first one is very simple. It's too complex. Well, if it is too complex to calculate the costs, how come that we then have a reimbursement system that can cope with that complexity? Simple question. They say each treatment requires or involves too many processes, too many actors, too many doctors, too many nurses, too many institutions to do whatever you would like to do in that cost. And also every patient is different. Sure, we're all different. That's fine. It's impossible to capture all these variations. That might be a possibility. So, the third one is, well, the variation in treatment itself is also very high. We have also what we call idiosyncratic care. That means that if you have the same condition and you go to two different doctors, you get different treatments. Because each doctor has developed its own treatment, and they say that. So it's very difficult to do that. Care is also not standard. It's really tailor-made to the specific patient. And there's also no insight in which resources are used in which processes. I mean, look at the hospital. There's a lot of people running there, but how would you tie these people then, or their cost of running in the hospital to these patients? And, well, by the way, if we have a kind of an average, we take all the cost of the cardiology department, we divide that by the number of patients, and then we have an average cost by patient. Do you feel that yourself, you're average? I don't. I mean, I'm a real specific guy, and I have my issues with health, so, and I hope you're not the same as I am, so everybody's. Now, the problem, what adds to the problem is that actually what people understand about what they mean by cost in healthcare, well, that depends on who you ask it. If you ask me what is cost in healthcare, well, then I say, okay, this is actually the surplus that I have to pay that my government doesn't pay. I'm Belgian, by the way, so we have a government-paying system. So actually, the cost to me is relatively marginal. Okay, but the cost to the society is not. If you talk to the government, they say, well, the cost is actually what we reimburse. But reimbursement is not a cost. The reimbursement is a sales price. It's not a cost. The sales price is not a cost. So there's something different. If you talk to a hospital, well, they might come the closest to what is actually the cost of care. And the cost is the monetary value of all the consumed resources, and consumed resources, not spent resources. Perhaps I'll explain that a little bit later. The consumed resources that were necessary to perform the treatment of a medical condition for a specific patient over a complete cycle of care. That would be the correct definition of what is costing, actually patient costing in healthcare. And cost is definitely not the same as reimbursement. There's no correct causal relationship involved. Reimbursement is something totally different. Very well known for its cardiac surgery all over the world. It's really one of the top hospitals in Belgium for that one. And at that point in time, the government wanted to change its reimbursement system, and instead of paying the doctors on a fee-for-service basis, they would like to do that on a what they call DRG basis, or diagnosis-related groups. Basically, what it comes down to is that they would say, okay, you use the cardiac to the euros, and that's it. Okay, well, whatever other things, we don't care, that's the 5,000 euro, good. Yeah? And of course, this hospital, since it had only the very sick patients, said, we're going to have a problem if they do that, because our patients are a lot more sicker than the normal patients in the Belgian population, so we are actually having a kind of fear of underfinance. So the development of that model was actually intended to help the hospital in negotiating with the government on how they should be reimbursed, basically. Now, in the end, and I'm going to tell you all the details, but in the end, the tendency towards the reimbursement on DRG did not came through in Belgium. It did partially, but not really, so it ended there. The model which we developed there was on an individual patient model, and we used the traditional ABC, rate-based ABC methodology. The results of the exercise were that we had a detailed costing report for each of the 30,000 patients that had visited the hospital in the year of 1997. Each of the patients had about 200 different activities that it was allocated, and so the cost was relatively detailed. Many internal cost optimizations have been identified and realized. This is not due to the calculations that we've done, but simply if you do a process, if you interview on processes, you always get to see some kind of inefficiencies into that one. And another one of which I'm relatively proud is that we influenced through the model the reimbursement of lab analysis in Belgium that was adapted based on the calculations that we've done in the model. So some of the reimbursement of the lab exercise or the lab exams that are being performed have been changed. But the story is not all that good in the end. There were some difficulties and some shortcomings. And it turned out that setting that model up in one time, the first time we did it, it worked fine. It took us about a year to build it. But then we found out actually that it was very difficult to maintain because it had a lot of variables in it. But the hospital is also a changing environment, so you need to be able to maintain that. We had some arbitrary allocations, but that was all fine. But also not all complexity could be modeled. I mean, healthcare is inherently very complex. And, every patient is different, and every time you see a doctor or nurse, they have to do different things adapted to the complexity. So we could not model all the complexity. That had also to do with the rate-based ABC methodology. And we had definitely also no insight and overcapacity. We allocated all the costs on a 100% basis, but of course not everybody works 100%. Had to do with the traditional rate-based ABC problems. It's resource intensive to maintain it. It can only handle limited complexity and is sometimes a little bit inaccurate, by which the time-driven ABC methodology has actually been developed. Now, how could we do it in a different way? Now, I'm going to try to explain you very simple using the example of Mr. Janssens. Mr. Janssens is a patient that visits his cardiologist for his yearly checkup, and he has the following process line. So he comes in at the first time, he checks in at the administration, he gets some work to be done there. Then he goes to the nurses take an APG, then the blood pressure measurement, and they let him do a bicycle test. Then he's allowed to speak to the doctor, who does a patient intake conversation, an echo of the heart, explain the results to the patient, and finally you're expected to pay for the visits, and then you can go home. So this is a very simple, it's not even complex, it's a very simple process of a very simple exam. Now, the way, if you use a time-driven ABC methodology to do that, what you're going to do is first you're going to estimate for each of the different steps, you're going to estimate the time. So in this case, administrative reception takes 7 minutes, APG 55 minutes, a bicycle test takes on average 15 minutes, and all the rest. And you see here also the different resource pools, I would call them, that work in here. Here's the administrative staff, they're all done by nurses, and this is done by physicians. Now, step 2 is you calculate the capacity cost rate. Basically, that is what is my cost per hour per different resourcing group, and you can do all kinds of calculations. Then you take into account that, for instance, if you take personnel costs, there's a total cost of 36,000 euros. They work 220 days. There's 8 hours a day, so they have in total 1,600 hours. We estimate that they only work 75% of their time, or at least they are there 100%, but they do work 75%. So we have 1,200 hours available during my period, and if I then take 36,000 divided by 1,200, I come to hours, I come to €0.5 per minute. And this is the calculation you do for all the rest of those. And then you can calculate the cost of this visit. The cost of this visit was, okay, we have the timings, the cost, €5 administrative, €70 nursing staff, and 48 euros for the physicians. So as such, the total personnel cost, just including personnel cost, is 60.6 euros. That's simply the way you can do it. Now, of course, you can say, okay, this is just average as well. That's true. But by calculating it in this way, you create also insight into capacity. Suggest that on one day, 30 patients come in, they all come in for the same exam, and then you can simply calculate is, okay, how much time I have 10 minutes to check up here by administration, nurses, or physicians. I have 30 of them. You can calculate how much time you actually put, and you can also see what is the unused capacity or what is the time that's still left over. So in this case, we have a total unused capacity of, during that day, 366 euros. So by thinking it in this way, you can simply calculate capacity. By the way, there's other methodologies to do this, but this is just only one. Until now, I just used averages, but of course, we're not average, okay? And basically, if you look at a little bit deeper and we go into the bicycle test, then we said it was 15 minutes, but that's not the truth actually. If you look into the process, it depends on whether your patient does what we call a 25 watt or a 50 watt test. And second, it also depends on how long you're capable of being on the bike. Now we've done this one. Give me 5 minutes. The case study in the cath lab. The cath lab is actually where they put all kinds of tubes into you and then go into your heart and blow balloons up and stuff like that. That's the cath lab. The plots are showing how many times these procedures were performed. And this is at the wheel curve. And what it suggests is that from all the procedures that are being performed, only 4 of them are reimbursed according to cost, or at least above cost. About 10 procedures are just break even, and all the rest is relatively loss-making. So, and this is typically what you see always there, that's the disconnection between the cost and the reimbursement. Reimbursement is totally lost from the actual cost. And this also creates, the strange thing is some of the doctors in the cath lab, they really specialize in this part of the procedures. And yet some others, and this is probably intellectually or better probably, to have a higher satisfaction from that one. But you can see what that is going to do to the income of the doctors. The income of the doctors here depends on what kind of procedures they do. So So the question is, are all these necessary? Yes or no? These definitely will be necessary. Yeah? But we actually don't know. We could also calculate the capacity. We saw this is the available capacity of the nursing department over different months. This is basically the effective capacity use. So there's some room for improvement. On the other hand, I would say, I think that some of the simplification which we used really calls that we have such a low capacity utilization. And then this is the last example. Idiosyncratic care by a doctor. We had the first procedure is a coronary plus ad hoc PCI, which was performed by a couple of doctors, and 2 of them really did a high number of them. And then we looked to what was the average material cost in each of those procedures by each of those doctors. And then you see that Dr. C is using 776 euros, while Dr. B is 484. Now, what explains that difference? Well, we looked at it, and detailed analysis of the consumption shows that there's no difference in the use of catheters. That is, what they put into your body to look actually. But there's a real differentiation in the number of stents they use. Stents are the kind of things that they put into there. Dr. B used 126 stents for 334 procedures, and Dr. B used 245 stents. Basically, 1 in 3 versus 1 on 2 actually. Now, what's good or bad? There you go. What would you like to have? I mean, if you're the patient.
Not standard procedure.
Huh?
Standard procedure.
A standard procedure? I don't know. I mean, if there were a catheter in your body and they say, actually, we should put a stent more, but the standard machine says, oh, you can put what? We don't know. The answer is actually what we need to do is we can't tell anything until we say also, what is the outcome measurement? What is Dr. A or B better than the other based on the outcomes, yes or no? So we need to see costs together with the outcomes. I think one of the reasons why costing in hospital has not been adopted is just because of that. Everybody thinks if we're going to focus on cost, we're going to reduce costs, and we're going to reduce quality. And we have no objective way of connecting the quality to the cost, actually. And by the way, we found similar cases in some other cases. And one last thing is the duality between the hospital and the assumption of equal outcomes for both doctors. What we have that is that Dr. B, who was using least stents for the cost for the payer and in the Belgium system, that's the government. The government is very happy. They're not that happy with Dr. B because that costs them a lot more. But if you look at it from a hospital's perspective that also invoice these stents, then the idea is totally different.